Okay, Deirdre, this is for you. So we were just talking about how we might recognize um, MH in a in a patient who's under anesthesia. And one of the things that the anesthesiologist might notice first is that if they have the patient set on the ventilator with a respiratory rate of 10 to 12, we mentioned this earlier, and then suddenly they see that the patient's overbreathing the vent, that is important. Many patients overbreathe the vent. That sometimes happens as they may be responding to surgical stimulus. But if they're overbreathing the ventilator and their end tidal CO2 is up, that really signals that there's a problem. So, in addition to that, so elevated end tidal CO2, also tachycardia and arrhythmias, even if it's just PVCs. Think about that. All right. So, what is MH? Exactly what it is. We talked about, what kinds of symptoms we might expect or signs. So complications, we talked about muscle breakdown. So muscle breakdown occurs, and that leads to all of the bad things: the metabolic acidosis, the hyperkalemia. The hyperkalemia can lead to arrhythmias. So that's part of everything, part of the problem. So why does MH occur? So there are 6 genetic mutations, and they are inherited as an autosomal dominant. So, if your mother or father has it, you're going to have a likelihood to have it, okay? And it may occur with other inherited muscle diseases, which you mentioned earlier, Duchenne's muscular dystrophy, and also central core disease. So in susceptible individuals, those patients that have the genetic predisposition, the triggering anesthetic agents will cause a problem within the muscle cell. Way back when, from your biology or biochemistry, you remember you have the muscle cell, and it has actin and myosin, and they ratchet along together, and that's how the muscle contracts, and it releases from the sarcoplasmic reticulum. Remember that word? And calcium is released. Well, in MH, the stored calcium in the cells is released, and the increasing calcium. So calcium is what you need for a normal muscle contraction. I'm going to lift some weights. I need that calcium to be there in order to contract. So the calcium is released, and it causes very vigorous muscle contractions, which can then lead to rhabdomyolysis, if I said that correctly. And that is all of that contraction of all the muscles can then lead to the development of hyperthermia. As the muscle starts to break down from all of that contraction, that's when you get, from rhabdo, you get the hyperkalemia. I think that is a good explanation for it, and it's the ryanodine receptor that has the abnormal genetic information. So that's why Ryanodex. But you probably won't ever need to know that. So don't forget the other things that can occur. Here we don't see patients with sepsis, but you can have, again, I mentioned earlier, neuroleptic malignant syndrome. Those are patients who are on SSRIs and getting a fair amount of narcotics. And also serotonin, so patients who are also on SSRIs. So SSRIs and even some of the newer antidepressants can lead to a potential for these crises that mimic MH. Anything else? I think I got you, Deirdre.
Just hit the red button.